Thank you for the invitation to the committee who invited me. It's very nice to be here in India to speak to you. I'm going to echo some of what Professor Vacharajani says. How do I move this? Okay. So the disclosure is I've only put in 2 personally. And the reason for that is that what Professor Vacharajani said is absolutely true. The indications for this device are so narrow that even with a hemodialysis prevalent population of 800 that I deal with and an incident population of 200, I've still only in the last couple of years come across 2 patients where I really felt it was the right thing to do. I had some help from Merit Medical, who are the company who make the graft for material for the presentation, and also got some pictures from Dr. Holman in Baylor, who's inserted many more of these than I have. The biggest experience in the UK is actually in Birmingham University with Nick Inston. They've put in about 20, so he has experience of dealing with the complications of insertion, which is what I was asked to speak about today. So what's this all about? Well, you've had talks about central venous stenosis and occlusion, and it's, as we said, it's the Achilles heel of vascular access. There is no good treatment for it. And when you see the hero concept, it sounds quite appealing, because the main reason for AV graft failure is stenosis at the venous end. And you would imagine that hanging the venous end straight into the atrium would overcome this. So the traditional treatment of superior vena cava obstruction or central venous obstruction was nicely covered by the previous speakers. In my unit, we use repeated angioplasty. Every 4 to 6 months, people come back whether they need it or not, and we just re-balloon it. I agree with the sentiment that once you start the process of ballooning, you're kind of obliged to keep going because these recur. We don't really use stents in our unit except for elastic recoil, and our experience with them, I have to say, is pretty poor. We much prefer to do repeated angioplasty if it's an option. And in fact, the majority of these are going to fail anyway, but we do have long-term patency with a repeated plasty protocol. And we've got people more than 10 years out who are just having repeated plasties on schedule. So it can work. So what's the hero graft? So Professor Vacharajani came at it as a nephrologist. He thinks of it as a line. I think of it as a long graft. But you can, really what it is, it's like a crush-resistant stent, isn't it? It goes all the way from the shoulder straight into the central veins. And then, as you said, you couple it up to a pre-existing AVF or a standard PTFE graft. So this is what it looks like. Now, I have to say, I have a problem with this picture, which comes from the company. How do you work? Everybody's having trouble with it. Is it? Yeah. So here's your graft coming up from the brachial artery. There's a connector here, and here's the novel part of the device, the outflow component. Now I want you to notice something. They've put it through an occluded vein here, but the other side is completely open. And they've put essentially a stent right across the open orifice of it. I think this is questionable, whether you should just go to the other side here rather than risk occluding the other side with something that has a 20% 1-year patency. It can be used for salvage, and in fact, I think this is probably the real indication for it. If you've got a pre-existing fistula and you've got recurrent stenosis and you can't overcome it, I think it's probably not unreasonable to run it into one of these devices. And the same for AV graft salvage, pre-existing graft, anastomosed onto the outflow component. Now, the key element, the thing that's new about this device is the outflow component. It's a silicone catheter with nitinol reinforcement. It looks like a garden hose when you take it out of the packet. It's very small. It's only got a 5 millimeter internal diameter. Now, you know the rule of 6s? That's smaller than the rule of 6, right? So that's a high resistance outflow, and it's really long. It's 40 centimeters long. Now, the average AV graft in an arm is going to be, 25, 30 centimeters, and you're going to start with 40 centimeters before you even attach it to the graft. Now, this is the indication for it, really. If there's literally nothing else you can do, and there's some reason you can't go to the legs, I think it's reasonable to think about this. Here's the venous outflow component over the line. The coupler, so the graft comes supplied in the packet. It's a thin wall PTFE graft. And it's got a little coupler where you just push it into the end of the line. And I'll come back to that, can cause problems. I'll come back to that later. So it just pushes in. And then you do a standard anastomosis to the brachial artery. You can use it through existing stents, as here in Dr. Homan's picture. And post-insertion, this is what it looks like. So he's drawn on the outside of the arm where it runs, and the connector is up around the shoulder area mostly. Here he's crossed from below and above, which is pretty standard. But if you can't get across, there have been a few reports now out of the US, out of Germany actually, not the US, where they're using the surfacer device, which comes from the same company. I think there was a presentation on it last year, but I'll just run through it quickly. This is a device that comes up from the leg, from the femoral vein. It goes into the stump of an occluded SVC, and then you put a marker on the skin, and then you just turn the screw at the bottom, and a sharp needle comes straight out through the skin. And then you can place a wire through this for through and through access. And you can either place a line, or if you want to, there have been a couple of reports of placing hero grafts through that access, which sounds quite appealing for some people, I have to say. The company have recently introduced this. This is an adapter to fit it to your early cannulation graft. And really these people are people who are running out of access, and often you'll want to cannulate this early in that type of person if it's an option. Basically what you do is you get your Goracuseel or your atrium flexine, and you slide it onto there, and then this bit snaps shut over the top, and then you push that into the venous outflow component, which saves you having to do an extra anastomosis, which is what people were doing previously. But that's about 150 pounds, whatever that is in rupees, like a couple of thousand rupees just for the connector. Now, this is a hybrid open and endovascular procedure, and I think it's best done in a hybrid operating theatre if that's available to you. And it doesn't matter who puts it in, but you're going to need open surgical skills and you're going to need good wire skills. So you either need two people or one person who combines that, and it does not matter what label they carry as long as they have the correct skills. This is ours at the Royal Free. Now, I was asked to speak about the pitfalls. So we start with the outflow component. The peel-away sheath can split the central vein if you start peeling it inside the patient. That's something to remember. So when you put this in, you need to get that peel-away sheath all the way out of the patient before splitting it down. We spoke about this before. The device is long and it's narrow, which is a recipe for thrombosis. And particularly if your inflow isn't very good. We're speaking about a blood pressure of 100 systolic. You need that at least. I think these things work best when there's been an access in the arm already and the artery is already developed. You know, when you make an access, it's not just the vein that matures, the artery also grows with it. And you need that kind of flow to drive this kind of graft. So what you need to do is take the inflow as high as you can on the biggest bit of the brachial artery that's available to you and keep the graft as short as possible, just enough to cannulate. So this is courtesy of Dr. Homan again. He's taken the inflow, look, right up there where you put the top end of a brachioauxiliary graft, proximal brachial artery, and he's tunneled it round the shoulder, and I'll explain why later. The graft also crosses a joint. Now, all vascular surgeons know this is another recipe for kinking and twisting, and constant movement can dislodge things. And the solution is always to bring it round the convexity. You bring it on the internal diameter, you'll get kinking. You bring it on the external, instead of compressive forces, you get stretch across it. So this is what he's done here. And on the last case also, you see that the graft isn't coming up here, and around it's going way up over the top of the shoulder. Even then it's going to clot. As you saw, 22% primary patency. So you may consider an antiplatelet or anticoagulation. There's no evidence for this. There are only small series reported, and there's nothing to guide you. The practice in some units is to anticoagulate these patients, particularly once they've had their incident thrombosis, and particularly if you can't find a mechanical reason for the thrombosis, you might consider anticoagulation. As Professor Vachurjani said, if it thromboses, the thrombus burden is going to go from the brachial artery at the elbow, the full length of the device. You're going to have nearly a meter of thrombus up the central part of the device. And you're going to need to be very careful with the declot. You shouldn't do, so in our unit, we often, when our interventional radiologists declot fistulas for us, what they tend to do is, if the fistula is not too big, they just blow serial balloons up and they send everything centrally. And the small clot, it's cheap and it's, you know, it works. And as long as you don't do it too many times, you probably won't get pulmonary hypertension. But anyway, but you can't do that in this. You cannot send that amount of clot centrally. It's going to need to come out. And endovascularly, that's a problem. You're going to need to use an angiojet, or you're going to need to use something expensive to clear that clot, or you're going to have to do open surgery. And you don't want to really be doing open surgery 2-3 times per year to declot these things. However, that is the recommendation, is that you do it in a hybrid facility. Now, Nick In-stent has worked on Nick In-stent is drawing up guidelines at the moment for how to declot these things safely, and that says something about the device in my mind. You should do it in a hybrid facility. What he suggests to do is open down near the arterial anastomosis and use Fogarty balloons over the wire to get out as much clot as you can. And then do an angiography and try and find the mechanical reason. He tells me that the most common thing that causes a problem is the coupler moving, kinking, and that may need open surgery and tacking down to straighten it out. If you can get away with, if it's just the other thing he's described is cannulation areas, bits of the graft being disrupted inwards, and those can be pushed back up. But the next recommendation is to, if you can't salvage it, to explant the vascular outflow component, because it's associated with significant thrombus burden at the tip, which can cause recurrent pulmonary embolus. And he says to overwire it and replace it with a tunneled line once you explant it. If you do get recurrent pulmonary embolus in a patient with a HERO, we suggest first anticoagulation, to do an echo or an angiogram to exclude thrombus at the device tip, and if it's still occurring on anticoagulation, the thing's got to come out. Now, he has this experience with 20 grafts, and again, I want you to keep that in mind if you're considering putting this in patients where it's genuinely not their last option. These are the benefits from the company. You've seen the other results from Tushar. And I did have a video, and I didn't think I would have time to show it, but Tushar was so succinct, I could have done it actually, so I'm sorry about that. Thank you.